Well, I was about to ask how you deal with the person whose approach is, if he's told me to do 3, then 30 must be better.
Yes. I would talk them through the reasons as why not. So something, like the novel stimulus effect. If you introduce something new, you're going to have a big physiological response and overshoot the mark somewhat. So I talk to them around that and say, really, you're going to get the most benefit from doing that. If you overshoot it, it can be quite sore, and you might really feel that for a few days afterwards. If that happens, stop what you're doing and go back to the 2 or 3 repetitions, say, that I recommended. So, and sometimes if someone is really driven and really doing a lot, you have to have that conversation with them about what is the purpose of exercise and training. So you might talk them through your stress response and adaptation curves and that kind of thing. I find that works really quite well. If they get an idea of that you're generating a stress and then you're getting a response which enables them to train better, then they can see that more. And quite often they're not aware of that. And often in that population of people that have chronic pain, they frequently have really become quite advanced athletes, but they're training like beginners. So the more advanced you become, the more specific you might have to be in what you do, and you might have to pick your priorities. So, after a certain point, if you're a marathon runner, you're not also going to be able to do, heavy squats and the rest of it because of the competing demand. So, but if you try and do lots of weightlifting, say, that's going to add to your general stress pool in the body, your general allostatic loading and that kind of thing. And then that may result in pain and inefficient training or overuse type injuries, which can become chronic in nature.
Seems in some ways to conflict with evidence that we've heard, good evidence that we've had discussed on the show before, which is that if, let's say, you have knee pain, then strength training, proper strength training, which means training to failure, is proven to give you good results in that. But of course, when we give that sort of advice to people, we're not dealing with a chronic pain patient, are we?
Yes, exactly. So this is where there is a difference between the acute and the chronic, and where we have to be aware of what that background of the patient may be. It's not that strength training is bad, but you might not start there. So say you had a chronic knee patient where they had those proprioceptive deficits. Do you want to train strength training to failure within that, where they don't have the appropriate control? I would argue that you're much better off starting with that proprioception approach, then building in strength training, which is going to be much more controlled and therefore efficient at that point.